Hello everyone, welcome to an academy. Let's crack the PG. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant in Bangalore, and also I am an educator in an academy. I have an experience of teaching undergraduate and postgraduate medical students. I have done my MPS and MD from Rajiv Gandhi University of Health Sciences. Today we'll be discussing about viral infections, all the infections which are common in the pediatric age group. We'll be discussing. So that will be the measles, mumps, rubella, varicella, and dengue viral infections, and the certain emerging new infections. What we are seeing in children will be discussed today. Okay, so this is going to be a 1 hour of a lot of it's going to be a lot of discussion happening with viral infections today. Okay, so before that, I would want to speak a little bit about an academy. An academy is yeah. Good morning, Triple Helix. Good afternoon, actually. Okay, so it is India's largest online learning platform, and there are a lot of benefits you can avail. Firstly, the daily life classes. The daily life classes happen every day, and you can attend these classes every day, and with your favorite educator. You can chat with your educator, engage in discussions, ask your doubts, and these answers will be cleared immediately. Also, have to have a structured course. So whenever you're preparing for your entrance exam, you need to plan well for your preparation. So you need to know by when I need to finish all my subjects, and from when should I start revising. So that should be planned well. And here in an academy, all these courses are structured in line with your exam syllabus, and that will be a huge boost for your preparation. Also, whenever you're preparing for your entrance exams, you need to evaluate yourself. You need to know what is your weak area, what is your strong area, and then uh, based on your evaluation, you can concentrate more on your weaker area. So especially here in Unacademy, there are a lot of live tests, quizzes, and mock tests happening, and if you participate in these, it will help you evaluate better. Okay, coming to the unlimited access. So once you subscribe to the subscription, you have unlimited access to all the classes. Okay, even the plus classes. So if you have skipped a live class, you can go back and watch these recorded classes again and again, and all this in the comfort of your home and the comfort of your device. Okay, so these are the top educators in the platform. There are regular classes happening, and all the 19 subjects which are required for your PG preparation are taught in this platform. Okay, and these are the ongoing courses happening in our platform. And now coming to the NEET PG subscription. So as you can see, the NEET PG subscription varies from 1 month to 24 months. So right now, for the people who are giving the NEET PG 2021, the 6 month subscription would be good enough. So the subscription, 6 month subscription is 20 comes up to 20,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 18,000. Okay, and for the ones like for the interns and for the final year students who are just preparing for their NEET PG 2021, I would suggest the 12-month or the 24-month subscription. The 12-month subscription will cost you 25,000, but using my code Shilpa 10, you get a 10% discount, and it will come up to 22,500. And for the two-year subscription, it will come up, it is 30,000, but using my code Shilpa 10, you'll get a 10% discount, and it will come up to 27,000. So I highly recommend this platform because see, these are the classes are planned well, and there are a lot of educators teaching you, so you can take your whichever educator you're comfortable with, you can go listen to their class regularly, and your concepts will be cleared better. Okay, also when you're preparing for your entrance exam, using this platform in the early part of your preparation will help you a long way. Okay, so now coming to today's topic, that is viral infections. Okay, so viral infections, but first I would, since this is a topic which includes fever always, okay, right, these infections will present to you with fever. So let us talk a little bit about fever. So in children, the temperature, body temperature is higher than the adults. Okay, so so we need to see the rectal temperature, axillary temperature, and the oral temperature. So actually the rectal temperature is preferred because it gives the core temperature value. Okay, but since it's not always possible in a clinical setup, so we use the axillary or the oral temperature. So the rectal temperature, if any temperature is above 100.4, is considered as fever. Okay, so the axillary temperature will have a difference of 1 to 2 degree Fahrenheit from the rectal temperature. So any temperature above 99 degree Fahrenheit in an axillary temperature is considered as uh, uh, fever. Okay, while oral temperature, so there will be a difference of 0.5 to 1 degree Fahrenheit when compared to the rectal temperature. So any temperature above 99.5 degree Fahrenheit is considered as fever for an oral when you check the oral temperature. So understood. So rectal temperature is the highest, which is above more than 100.5, 100.4. Then comes the oral temperature, which is the 99.5. Then the axillary temperature above 99.5. Okay, and the temperature in children is more than the adults always. Okay, yeah. So coming to today's topic, so today we'll be talking about measles. Okay, so measles is also called as rubeola. Okay, so don't confuse with rubella. So suddenly when you see a question, you shouldn't confuse yourself with rubeola and rubella. So always measles is rubeola. Okay, so measles virus is a RNA virus, and it is from the paramyxo virus family. Okay, so how is it spread? So this is spread by a second, yeah, so this is spread by a droplet spread. So droplet spread. Okay, so that is from the secretions of the from the mouth, from the nose. So that is how the infection is spread, and this has a very high secondary attack rate. So right now we talk about R naught, right? So R naught is something it's the speed at which the infection spreads. Okay, so this measles has a higher R naught value when compared to even coronavirus. Okay, so the secondary attack rate is up to 90% of a measles virus. Okay, so this virus, once it enters into the body, it multiplies in the respiratory epithelium. Okay, and then it will affect the it will lead to the it will affect the reticular endothelial system. So first it multiplies in the respiratory epithelium and then goes to the reticular endothelial system. Okay, so the incubation period is 10 days, around 10 days. Okay, so now coming to the clinical features. Okay, so it is common in preschool going children. Okay, so these children are protected from um, uh, the maternal antibodies. So transplacentally the maternal antibodies cross over to the fetus, and these children are protected from measles for up to 9 months. So that is why the vaccination for measles is done after 9 months. Okay, so there is placental transfer of antibodies. Okay, so now how do these children present? Okay, so there is a prodromal phase. So prodromal phase are generally these children, it is a mild vague symptoms. There will be fever, there will be cold, there will be cough. Okay, so and there will be conjunctival congestion. Okay, so another thing very important about measles is the Koplik spots. Okay, so this you need to remember for your entrance. Okay, Koplik spots. So Koplik spots are pathognomic of measles. So where are they found? So this is an erythema which is found at the opposite side of the lower second molars. Okay, it is found in the buccal mucosa. Okay, there is a erythematous, small erythematous spot. Okay, that is below the lower second molar. So you should remember that. So this is very important. This is pathognomic erythema, erythemic spot, I can say. I will show you a picture at the end. This is present in the lower opposite lower second molar. So this is very important more than all these. So you all know all these viral infections spread either through the droplet spread or through the airborne spread. Okay, so more than everything you need to know for your NEET PG, you need to know such pathognomic features. So such things will come. Okay, so Koplik spots. So these appear on the second or the third day of the illness. Okay, so they are present, that is over. Then slowly what happens, once first the fever comes, and after that from the fourth day there might be rash happening. So first the rash happens behind the ear, and then slowly it goes to the posterior part of the cheek, and then these rashes gradually become maculopapular and spreads to the face, neck, chest, trunks, thigh, everywhere. Okay, so first it is in the posterior part of the ear, and then to the posterior part of the cheek, and then it spreads. So first it is a macule, you can see, oh, the reddish patch, and then it becomes maculopapular. Okay, so then by 10 days the rash will slowly fade away. Okay, so this is how a measles presents. Okay, so now coming to the complications. So there are a lot of complications in measles, because so the thing is, if the measles are infect a immunocompromised person, then there is a lot of widespread mucosal damage happening, and that can lead to even mortality. Okay, so the complications you need to know, this is very important. So you need to remember what are the complications. So complications are, one is otitis media. Okay, so and then there is bronchopneumonia. Okay, and also what are the other respiratory complications you need to know is, so there could be laryngitis, tracheitis, bronchitis. Then there is giant cell pneumonia. Remember this giant cell pneumonia, you need to remember, they might ask giant cell pneumonia. Okay, bronchiectasis. And if, see, in our body you have latent mycobacterium tuberculosis. So in a child who has latent mycobacterium tuberculosis, and if the child has measles infection, this latent mycobacterium tuberculosis can flare up. Okay, so all this you need to know. And very important is the SSPE, that is subacute sclerosing panencephalitis. Okay, so this is asked. So this is also asked in your NEET PG. So giant cell pneumonia is another one complication. Another main complication is a subacute sclerosing panencephalitis. So this occurs in 1 to 2 per thousand children who are affected with measles. Okay, so this happens during the so what happens is, yeah, so there is an immune mechanism which is happening in the brain, and that is how this encephalitis happens. Okay, so remember, so certain names you need to what is H pneumonia, is it? No, no, giant cell pneumonia. Remember, it is giant cell pneumonia and SSP. So these are the complications you need to keep in mind. So other complications like otitis media, bronchopneumonia, you'll know. But certain names, specific names for complications like giant cell pneumonia and subacute sclerosing panencephalitis, you need to know. So how do you diagnose? So first of all, the diagnosis is clinical. And if you get a blood test done, you should get IgM, immunoglobulin M, estimation should be done. Okay, immunoglobulin M, anti-measles antibody should be done. So treatment is supportive. Okay, you give antipyretics, you give fluids. If there is secondary bacterial infections, you give antibiotics. Okay, so this is how you manage. And also, if the child with measles come to you, you have to give vitamin D supplementation. So if a child of less than 1 year, you give 1 lakh units of vitamin A. More than 1 year, you give 2 lakh. Okay, vitamin A. So this is about measles. Okay, so the prevention is by MMR vaccine or the measles vaccine. So the measles, what is the strain? I had told you in the quiz as well as my immunization class. This the strain is Edmundston, Zagreb strain, which is used in the measles vaccine. Okay, so this is all about measles. So I have to it's nothing more than this can come. Okay, so next, so this is the red spot. So you can see this. So this is the red spot which I was talking about. That is the Koplik spot. complex spot. Okay, so this is it looks like this. So in the buccal mucosa opposite the lower second lower molars. Okay, fine. So now coming to mumps. Okay, so mumps is a virus which is a RNA virus, and it is from the paramyxoma virus family. Okay, paramyxoma. So it is same as measles. Okay, mumps virus is an RNA virus which is from a paramyxoma virus family. So what happens? So we hear children between 5 to 15 years are affected. Are affected. Okay. So, and man is the only reservoir. Okay, so this is by either droplet, airborne droplet spread by fomites. Okay, you touch like you rub your face. I mean, you have mumps and you rub your face with the all the secretions, and you keep it somewhere else, the napkin, and if someone else touches it and spreads it over their face, this is how it spreads. So fomite transmission, airborne and fomite transmission. Okay, so this is how the transmission happens in mumps. So how, what is the clinical feature you need to know? So incubation period is 2 to 4 weeks. So this is a very long incubation period. Okay, so here how do these children present? So initially they present with fever, malaise. Okay, there might be headache. Okay, and eventually slowly they might have a swelling in the cheeks. So the salivary glands are involved, and the most common gland to be involved is the parotid gland. Parotid gland. Okay, parotitis. So there can be unilateral or bilateral swelling of the parotid gland. Okay, bilateral swelling of the parotid gland, and so that time what happens, they might come with the either the jaw pain while chewing, and even this ear gets pushed back. Okay, because of the swelling. Okay, so that is the how these children come to you with mumps. So one is the incubation period is between 2 to 4 weeks. So what are the complications you have to know about? So the complications are, so these children can present with aseptic meningitis. Okay, so mumps is one of the very common cause for aseptic meningitis, and other neurological complications could be, they could present Guillain-Barré syndrome, transverse myelitis. Okay, so how do you diagnose these children? So you get a, first of all, this is clinical diagnosis is clinical, but in these children there is elevated serum amylase. Okay, also when you get the immunoglobulin M, anti-mumps antibodies, that will be elevated. Okay, so again, symptomatic management, you give antipyretics. If there is secondary bacterial infection, you give your antibiotics. Okay, so now coming to rubella. So the rubella is called as a 3-day measles, or also the third third fever, third disease, sorry, third disease. Okay, so rubella is also called as third disease, or the 3-day measles. So now the rubella virus is a RNA virus. Now you can see the difference. It is a Togaviridae family. Okay, so you need to remember all this. It might look very silly, but remembering the family of the virus also matters. Sometimes it might come as a question. So remember. So in measles, mumps, and rubella, measles and mumps are RNA viruses from the myxo family, while rubella virus is a Togaviridae family. Okay. Now coming to the etiopathogenesis of rubella virus. So once this virus enters the body, so this will replicate in the respiratory epithelium, and then it will go to the lymph nodes. Okay, lymph nodes, and then by 10 to 17 days there will be an intense illness. So in these how do these children present as? So these children will present as with fever. Okay, so the fever and the fever, low grade fever will be there, and the incubation period of this is between 14 to 21 days. Okay, also there could be sore throat, eye pain, petechial hemorrhages. Okay, especially in the soft palate. So this petechial hemorrhages in the soft palate is called as uh, Forchheimer spots. Okay, so this I there is a picture of this, I will show you. So that is again an MCQ which has come. Okay. Okay, so between 14 to 21 days is the incubation period. Okay, so first the rash presents on the face, and then it spreads to the entire body. Okay, so another very important thing in rubella is, if a pregnant mother has rubella, chances of developing congenital rubella syndrome is very high. Okay, yeah. So what is the diagnosis? So again, diagnosis is the elevation of, there is elevation of IgM, anti rubella antibodies. Then you can diagnose rubella, and also it is very clinical. Okay, so the complications, again, there could be thrombocytopenia. See, I'm doing a very fast thing which is only important for your exam point of view. Okay, thrombocytopenia, arthritis, encephalitis. Also, there is something called as progressive rubella panencephalitis. So this is very rare, but this is similar to the subacute sclerosing panencephalitis which happens in measles. So there is progressive rubella panencephalitis, PRP. Okay. So what is the treatment? Again, the treatment is symptomatic management. So what is the in the MMR gene? Uh, the rubella vaccine is there. So what is the strain which is used in the rubella vaccine? Anyone knows who's watching? Yeah. So the rubella strain is the RA27 by 3 strain. Okay. And I forgot to talk about the mumps vaccine. So what is the mumps strain? Yeah, very good, very good. What is the mumps strain? Try to remember. What is the mumps strain? That is the Gerald Lynn strain. Gerald Lynn strain. Lynn. Gerald Lynn strain. Okay, fine. So this is was for mumps, rubella, and measles. So now coming to, okay, and this is the Forschmeier spots. Okay, so this is seen in the, so these dots, what you can see, the erythematous dots, what you can see is seen in rubella. Okay, so that is called as Forschheimer spots. Forschheimer spots. This is seen in rubella. Okay, so there are two types of spots, which one is a Koplik spots, which is seen in measles, and then there is Forschheimer spots, which is seen in rubella. Okay, fine. So now coming to the varicella. So varicella, also called as chicken pox. So this is caused by the varicella zoster virus. Now coming to DNA viruses. So this is a DNA virus which is from the herpes virus family. Okay, so so again, the route of spread is, one is respiratory, so or the airborne spread, or the direct contact. Okay, so this virus goes to the respiratory epithelium and it multiplies, and then then it spreads to the different parts of the different organs. Okay, so first of all, the period of infectivity is 24 to 48 hours before the rash develops. Then it will spread up to the time the crust is the lesion's crust. All the lesions should crust. So the child might just come with you with fever, that and they might not be rash. By even then, before that only, the child will be, even before the rash develops, the child will be infecting, will be infectious. Okay, so 24 to 48 hours before the rash develops, till all the lesions crust, the child is infectious. Okay, so now over here, what is the secondary attack rate? So here the secondary attack rate is 80%. So measles is the highest, okay, 90%, while varicella chickenpox is 80%. Okay, so once you have this infection, there's always this latent infection in the sensory ganglia, which gets reactivated whenever your body is sensory ganglia. So whenever the body is compromised, okay, so that will present as herpes zoster. So there will be ectodermal rashes. So in a line in your body there will be rashes. So that is called as herpes zoster. So that will be reactivation of the latent varicella virus. Okay, so how do these children present? So first of all, in the prodromal phase there will be a fever, lethargy, fever, then body aches, okay, and cold or headache. So that will be there. So slowly there will be a rash which presents. So first there will be a macular rash, erythematous macular rash. Then it becomes papule, then it becomes a vesicle. So now you see there are three stages. There is macule, there is papule, there is a vesicle. So a child can have macules, papules, vesicle, because there are a lot of rash in the body, right? So it can be in different stages. So this different stages of the rash is pathognomic of varicella. Okay, so this is called crops of several crops of lesions. Several crops of lesions. So different type of lesions will be there. So that is a characteristic feature of chickenpox, varicella. Okay, yeah. So this is how we what is it, diagnose chickenpox. And also they what do they say is it is like a dewdrop on a rose petal. Okay, the lesion is called as a dewdrop on a rose petal. That is because now if this is the vesicle, around the vesicle it is reddish erythematous. So that is why it looks like a dewdrop on a rose petal. Okay, so this is how a varicella presents. So now what are the complications you need to know? So if there is a secondary bacterial infection of the lesion, it can lead to necrotizing fasciitis. Okay, these lesions which happen in because of chickenpox takes a very long time to heal, and on that if it becomes secondary infected, it can lead to necrotizing fasciitis. Okay, so what are the neurological complications which happen here? Complications, so one is meningoencephalitis. Okay, there could be acute cerebellar ataxia. Okay, transverse myelitis, optic neuritis. So just remember there is encephalitis happening in these children. Remember about acute cerebellar ataxia. Rest everything is same in all the viral infections. Meningoencephalitis happen. There can be Guillain-Barré like syndromes. There could be what is it, transverse myelitis. So these all happen in all the viral infections. But there are certain things we specific to this you remember. Okay, so acute cerebellar ataxia, and if the lesions are secondarily infected, that can lead to necrotizing fasciitis. Okay, also these children so these children have a can lead there is a chance of developing Rey syndrome. So that is why these children shouldn't be given aspirin. Okay, yeah, fine. So there is something called as progressive varicella syndrome. Okay, this is a very severe complication of varicella. So what happens is there is development of hemorrhagic lesions, then there is coagulopathy, all visceral organ involvement is there. So this is called as varicella, progressive varicella syndrome, one of the complications of varicella. So how do you diagnose? So how do we diagnose? So one is, this is very clinical, but you need to differentiate all other erythematous lesions. So there is hand, foot and mouth disease that also comes with lesions, so you need to differentiate. So one of the way how you can differentiate is Sang smear. You do Sang smear. So this will show multinucleated, remember this, okay, this is very important, multinucleated cells. So Sang smear. Okay, this will show multinucleate cells, and this is how you can differentiate chickenpox from other infections. Okay, so herpes zoster, varicella and all, they come positive in Sang smear. Also when you demonstrate IgM, anti varicella antibodies, that will be increased. So treatment is symptomatic. So another thing is you can give acyclovir. Okay, so acyclovir becomes very effective if it is given within 24 hours of the appearance of rash. So if you have one single rash and that is detected within 24 hours, so that time acyclovir becomes very effective. Maximum 24 to 48 hours. So beyond that, the effectiveness of acyclovir is not much. Okay, so it will reduce the number of days of the rash. That's it. Okay, so acyclovir, so within 24 to 48 hours of development of the rash, if then acyclovir is given, it is very helpful. Okay, so IV acyclovir is, this is oral. I was talking about oral, 20 mg per kg per dose in four doses you have to give in a day. If the patient is in a complicated varicella state, then you go for IV acyclovir. Okay, so this is what you need to know. So next, coming to infectious mononucleosis. So which, yeah, so the dose is 20 mg per kg. So the dose is 20 mg per kg per day. Mg per kg per day. So this is given 4 times a day for 5 days. Okay, that is for acyclovir. That's the oral dose. Okay, if you're giving IV, it is 10 mg per kg per day every 8 hours. That is for 14 days. That is in complicated cases you give IV. Okay, yeah. So now coming to infectious mononucleosis. Infectious mononucleosis. In infectious mononucleosis is caused by Epstein-Barr virus. So this is the DNA virus. Again, this is from a herpes virus family. Okay. So now, what is this infectious mononucleosis? So there is over here fever will be there, fatigue will be there, lymphadenopathy will be there. So this is very important. There is lymphadenopathy. So one of the time, so when a child comes with a generalized lymphadenopathy, you have to always keep in mind about infectious mononucleosis. How does this spread? So this spreads by oral secretions. So in kissing, sharing your the plate while you eat. So this is how the infectious mononucleosis spreads. Okay. Um, so this is again, how does this what is the etiopathogenesis? So this virus spreads to the oral epithelial cells. So all this time I was talking about respiratory epithelium, right? So in infectious mononucleosis, this virus goes to the oral epithelial cells. Then it goes to the salivary glands. Okay, there it will affect the B lymphocytes. Then it goes to the blood, to the lymphoreticular system. So that is the lymphoreticular system, that is the lymph nodes, the liver, the spleen. So that will go to the lymphoreticular system. So the CD8 lymphocytes proliferate to check the replication of the virus. Okay, that don't need to remember that. So now clinical features, how do you know? So this is more common in older children. Okay, so again they have nausea, vomiting. Okay, so when you examine their throat, there is redness in the pharyngeal. Pharynx will be red, erythematous. Okay, then you can see petechiae at the junction of the soft and the hard palate. Okay, petechiae, okay, at the junction of soft and hard palate. Very important, lymphadenopathy. Okay, cervical is more common, and then the axillary and the inguinal, it's mild, but cervical lymph nodes are highly enlarged. Okay, then there could be splenomegaly or hepatomegaly. Okay, that is not 100% present. 50 to 60% of the times there could be hepatomegaly and splenomegaly. Okay, so now sometimes this you need to remember. So in children who have taken amoxicillin or ampicillin, okay, that time there could be a maculopapular rash. So that time you have to keep in mind about infectious uh, mononucleosis. Okay, so a maculopapular rash following a amoxicillin or an ampicillin ingestion, then you should think about infectious mononucleosis. Okay, so now what are the complications you have to see about complications? So complications over here, this is very important. There is chances of splenic rupture even with minor trauma. Okay, so there could be airway obstruction because there is enlargement of the adenoids. Okay, there could be seizures, meningitis, myocarditis. So these are all there, but main thing you need to know is splenic rupture, and also there could be airway obstruction because of the enlargement of the lymph nodes, that is the adenoids especially. So airway obstruction. So others are myocarditis, seizures, meningitis, thrombocytopenia, aplastic anemia are there. So remember about splenic rupture and airway obstruction enlarged because of enlarged adenoids. Okay, so how do you diagnose? So diagnosis is done. So one thing is there is leukocytosis. Okay, so you get a Paul Bunnell test done. Remember this Paul Bunnell test. Okay, so this Paul Bunnell test is a screening test for infectious mononucleosis. Another thing is the IgM, antibodies, which is against the Epstein-Barr virus. So these things you need to remember. The Paul Bunnell test is very important. So they might ask you Paul Bunnell test is done in which disease. So infectious mononucleosis has a lot of things. Okay, so what is the treatment? So treatment, you one is it's symptomatic treatment. And these people should not be sent to any what is it rigorous exercise or any sports, because there is a chance of splenic rupture. So remember, bed rest is very important in these children. Okay, and you can give a course of prednisolone. Okay, prednisolone, if there is any hemolytic anemia, if there is meningitis, you can give a dose of prednisolone. Another important thing is you can give intranasal steroids. Tell me, why do we give intranasal steroids? Triple helix, tell me, why could we give intranasal steroids? So intranasal steroids is given in order to reduce the reduce the enlarged adenoid so that they can breathe better. Okay, so that is why intranasal steroids is given. So if the management is symptomatic, but bed rest is very important in order to prevent splenic rupture also. Yes. Okay, so intranasal steroids is given so that the adenoids adenoids are shrunk. It gives a symptomatic what is it, the inflammation reduces, and it gives a symptomatic uh, relief to your nasal obstruction. So that is why intranasal steroids is given. Okay, so we'll come back and revise again. This infectious mononucleosis has a lot of things to remember, so we'll come back. Next, coming to roseola infantum. So roseola infantum is called the sixth disease. So how I remember is it's a 6 month old baby, 6 month infant whose name is Rose. So that is how you can remember roseola infantum, which is the sixth disease. It is also called as sixth disease. Okay, so this is caused by the human herpes virus 6 and the human herpes virus 7. So wait, I'll change to this. Human herpes virus 6 and the human herpes virus 7, which is the DNA virus, and it comes under the herpes family. Okay, now what is the clinical feature? So this is also called as exanthum subitum. Okay, so now what happens over here is, so this the peak age for this is between 6 months to 3 years. So remember, it's an infant, that is why 6 months to 3 years. Okay, so there is, in the prodromal period, there is upper respiratory signs, like there is cold, there is a nasal discharge, there is cough. Okay, so this is in the prodromal period. Okay, so these children can present with febrile seizures because the temperatures go very high. Okay, and the fever suddenly reduces. First thing is, how is the rash? So the rash is discrete. So if this is the, you just imagine this is the hand or something, so there'll be discrete erythematous rashes. Okay, so first it presents in the trunk. Okay, trunk, and then it goes to the face, neck, and extremities. So over here the rash presents in the trunk, and then it goes to the face, hand, and the, what is it, face, hand, neck. Okay, so now this is not it is not itchy, and this fades in 3 to 4 days. 3 to 4 days it will reduce. Okay, the what is it, the prognosis of roseola infantum is very good. It subsides on its own with antipyretic management. It comes down on its own. This roseola infantum is also called as the sixth disease. Okay, so next is coming to erythema infectiosum. So erythema infectiosum is also called as the fifth disease. So how will you remember fifth disease? So how do I say is A, B, C, D, E. So E is the fifth letter, right? So that is how is the fifth disease. So this is how you remember erythema infectiosum, which is the fifth disease. Okay, so this is caused by parvovirus B19, which is a DNA virus. Okay, so how do these children present? Okay, and these and so remember this is called erythema. Okay, and they have an inclination to all these erythroid cells, erythroid lineage cells. Okay, so remember it is caused by parvovirus B19. It's a DNA virus, and it has an inclination towards the erythroid lineage uh, cells. Okay, and this word itself, erythema, you can remember that in your mind. Okay, so the peak age is between 5 to 15 years. Okay, and the infection, yes. Hi Vishal. Yeah, yeah, aplastic crisis. Parvo B19 is very commonly associated with aplastic crisis. Yes, 5 to 16 years, 5 to 15 years, and the root is the respiratory root. Okay, so now these have a prodromal phase. As you all know, most of the viral infections has a prodromal phase. Then the rashes happen. So over here in erythema, so remember erythema, so there is flushed face. Okay, so first there is no rash as such. The entire face looks flushed. Okay, there is increased, so flushed face, face is flushed, so it gives a slapped cheek appearance. Slapped cheek appearance. Okay, and this the flushing, the redness, what is it, spreads to the entire body. Okay, and then later what happens, there is central clearing. There will be, what happens now, just imagine the entire body is flushed like this. Okay, entire body is flushed like this, and then what happens, there is small clearings. Okay, small clearings like this, so it will give a reticular, now you can't make out, but it will give a reticular pattern. Okay, so that is how the children present over here. So first there will be flushing, and then there will be central clearing. Okay, so there will be central clearing, and then they'll have a reticular lacy pattern, lacy or reticular pattern in the skin. Okay, so this is how they present. So what are the complications of a child with erythema infectiosum? Complications. So complication one is arthropathy, one there is idiopathic ITP, idiopathic thrombocytopenic purpura, then there is aseptic meningitis. Okay, so management is symptomatic, and these children have a chance of going to transient aplastic crisis. Okay, transient aplastic crisis. Okay, so triple helix was right, they'll go to a transient aplastic crisis. So as you all know, parvovirus is a virus which causes aplastic crisis in all these children with certain hemolytic anemias. Okay, Yeah, hydrops fetalis also correct. Hydrops fetalis in pregnant women. So if there is a erythema infectiosum in a pregnant woman, so that can lead to hydrops fetalis. Very good, very good. Okay, so management is symptomatic. Okay, so this we'll go to the next this thing. Next is poliomyelitis. Okay, so poliomyelitis is from the enterovirus genus. Okay, so the enterovirus has a lot of other viruses. So tell me some examples for enterovirus. It's there in the next topic. That is why I just want to know if you all know about it. So enterovirus. So this Coxsackie, Coxsackie, echovirus, all this comes under enterovirus. Okay, so the poliovirus comes under enterovirus. So that is in the Picornaviridae family. Okay, so now what happens? Now what has happened? What is the etiopathogenesis? So how does it happen? So this is spread by the fecal-oral route. Okay, fecal-oral route, also by the oral pharyngeal route. Yeah, hand, foot, mouth, and disease. Yes, correct. Oral pharyngeal route. Okay, so the fecal-oral route is more common in the developing countries, and this is in the developed countries. Okay, so now coming to the clinical features. So now the clinical features are divided into four. Okay, one is the abortive polio. So these will have low grade fever, sore throat, and then slowly the symptoms comes down. Okay, so there is nothing much. So there is no paralysis. Okay, so more like a prodromal symptom. Next is the non-paralytic aseptic meningitis. Okay, so these will have headache, neck and back stiffness will be there, and then they'll recover in 2 to 10 days. Okay, so not no paralysis happen, but that's why it's called non-paralytic aseptic meningitis. Next comes the paralytic poliomyelitis. Okay, so over here there is two phases. Okay, one is minor phase, another is the major phase. So in the minor phase they'll have features of abortive polio. Okay, so next in the major phase what happens, this will go to major phase. So in major phase what happens, there will be muscle pain. Okay, there will be muscle pain, there will be spasms, and the fever will again come back. Okay, and then there is rapid onset of flaccid paralysis, which will complete within 72 hours. Okay, so first these children will have a minor phase where there is abortive features, like there will be fever, headache, cough, and all that. Then this will further lead on to a major phase where there will be a sudden spike of fever, and then there will be muscle pain, spasms, and then it will go to sudden acute flaccid paralysis. Okay, so next is the spinal paralytic poliomyelitis. So the spinal paralytic poliomyelitis is a severe form. Okay, over here there is quadriplegia. Okay, so the muscles become floppy. Okay, then there is paralysis of the trunk, this is the abdominal muscles, all that is paralyzed. So the muscles becomes very floppy and the reflexes are diminished. Okay, so now first what happens, the paralysis happens to the proximal part of the muscle group, and then it will slowly spread, and it will spread to the distal part of the muscle group. Okay, if there is bulbar polio, what is bulbar polio? There is respiratory insufficiency, there will be difficulty to swallow. If there is bulbospinal insufficiency, there will be both the spinal paralysis, also bulbar paralysis. So bulbar, so in this spinal paralytic poliomyelitis, there is bulbar polio, and then there is bulbospinal bulbospinal polio. So what happens in bulbar? Again, the in bulbar there will be respiratory difficulty, there will be respiratory insufficiency, then there is difficulty to swallow. Okay, so this is how a child with poliomyelitis presents. So now what is called as residual paralysis. So now this paralysis, what happens in polio, they will try to recover. Okay, so in the first 6 months there will be fast recovery. Okay, then after 6 months to 2 years, there will be slow recovery. Okay, beyond 2 years, there is no recovery of this paralysis. So after that, whatever paralysis remains in our body is called the residual paralysis. So this child has residual paralysis of polio. So up to 2 years, you can wait and see how much recovery happens. So in the first 6 months, fast recovery of the paralysis happens. After 6 months to 2 years, it will be slow. Then beyond 2 years, there is no recovery of the paralysis. So after 2 years, this child has a this much percent of residual paralysis of polio. You can tell. Okay, that is called post-polio residual paralysis. So now how do you diagnose these children? So diagnosis is very important. The history is very important, and then there is a characteristic history of how did this flaccid paralysis happen. Okay, so you have to do stool examination. Okay, so stool is generally detected up to 8 weeks or more than that also. In the stool, the polio virus is detected, but it is best 2 weeks from the onset of paralysis. Okay, also a CSF test should be done to rule out other conditions. Okay, okay, so now the main in India right now, the main thing is the vaccine associated paralytic poliomyelitis. Okay, now tell me, what is the vaccine which strain causes vaccine associated paralytic poliomyelitis? Triple helix knows this answer. Now you have to tell this. Okay, so which strain gives me not in IPV, in the OPV. Okay, whichever IPV, OPV, which causes vaccine associated paralytic poliomyelitis. There are three strains, right? 1, 2, and 3. No, sorry, not strain. The type 1, type 2, type 3 of the polio virus. Type 2, yes, correct. So that's the answer. So type 2 causes vaccine associated paralytic poliomyelitis. Okay. Next, now coming to the diagnosis. Diagnosis is over. The differential diagnosis. So there is nothing as such to differentiate a polio because of a wild virus or because of a vaccine associated polio virus. So there is nothing as such, but you have to have a differential diagnosis whenever a child comes with polio. So first of all, you have to rule out Guillain-Barré disease, transverse myelitis. So these are the main conditions which you have to rule out, and also traumatic neuritis, rabies, meningitis, encephalitis. But the two main things which you have to rule out is transverse myelitis and Guillain-Barré syndrome. So this is about poliomyelitis. So how do you treat? So these children, so if the leg there is paralysis of the leg, so these children are managed at home. But if there is bulbospinal polio, then these children have to be hospitalized because there will be difficulty to breathe, there is difficulty to swallow. So if there is a bulbospinal poliomyelitis, these children should be hospitalized. So once they start recovering their power, then these children have to go for physiotherapy, ambulation. Okay, all these what is the multidisciplinary rehabilitation should be done. Okay, so this is how a polio child presents, and this is how we manage. Fine. So now going to hand, foot, and mouth disease. So hand, foot, and mouth disease is caused by the virus of the enterovirus genus from the Picornaviridae family. Okay, so all the viruses from the enterovirus genus can cause hand, foot, and mouth disease, but the most common which causes is the Coxsackie virus A16 and the enterovirus 71. Okay, so remember this, Coxsackie virus A16 and the enterovirus 71 causes hand, foot, and mouth disease. This is the most common virus in the enterovirus group which causes hand, foot, and mouth disease. Okay, so now how do these children present? So there is a prodrome. So you by now, I think by this part of the class you should be knowing. So most of the viral infections, they will have a prodrome. Okay, it will be either upper respiratory or infection, sore throat, they'll have fever, malaise, all that is prodrome. Next, what happens? They'll develop blisters. So hand, foot, and mouth. So first there is blisters in the oral cavity, especially in the posterior part of the oral cavity, in over the hard palate or the soft palate. Okay, there you can see ulcers or blister. Okay, so generally they present with a blister and eventually there will be an ulcer. So this is how a oral blisters. Okay, then there will be around the oral around the lips, hands, feet. So there you can see blisters, and then eventually they might what is it, rupture, and there might be a wound. Okay, so these children, so the illness resolves by 4 to 5 days. So these children present with fever, irritability, and these blisters. Okay, so first feature is in the posterior part of the oral cavity you see a oral blister. So next, what are the complications? So complications are, so these children can lose loss of nails, or in the toenails of the finger or the toe. Okay, so there will be loss of nails. This is in the this is a temporary what is it, complication of hand, foot and mouth disease. So there are rare complications like encephalitis, meningitis, myocarditis is there. Okay, so there has been mortalities because of hand, foot and mouth disease, especially when they were affected by enterovirus 71. Okay, so when there was a epidemic because of enterovirus 71, there have been cases of mortality, especially in countries like China, Vietnam, Malaysia, not in India yet. Okay, so this is about hand, foot and mouth disease. So main thing you need to remember is the Coxsackie virus A16 and the enterovirus 71. You need to know there is blisters happening, especially in the posterior part of the mouth, and the complication is, one is the loss of nails. So they might give you a clinical scenario. Okay, so this they might give a scenario where a child came with fever, there were blisters, and eventually the child had loss of nails, fingernails. So that is how you should keep in mind, this could be hand, foot and mouth disease. Okay, because there will be a lot of erythematous infection. So how will you know? This is how a child with hand, foot and mouth disease presents. Okay, so now coming to dengue. So you know dengue is very important. Why is it important? Because a lot of dengue cases come now. Okay, so dengue virus is a RNA virus which comes from the Flaviviridae family. Okay, so now this is caused by the the vector is the Aedes aegypti. Aedes aegypti mosquito. Okay, so this is how it spreads, and this is the RNA virus. um, I feel this is more than enough for you all. If you remember, this much is enough. So now coming to the clinical features. So the clinical features is divided into 4 phases. Okay, one is the febrile four ala 3 phases. One is the febrile phase, one is the critical phase, next is the recovery phase. Okay, so in the febrile phase the child will have fever, there will be high grade fever. Okay, at least for 2 to 7 days. There will be facial flushing. Flushing is another feature. Okay, you should remember, flushing will be there, fever will be there. Okay, so here you should get a tourniquet test done, so in other, so that clinically you can confirm this could be dengue. So what is a tourniquet test? So tourniquet test is, you put a blood pressure, a BP cuff, and inflate it between the systole and the diastolic blood pressure, and then check for erythema, what is it, petechiae. So in a what is it, 1 square inch, 1 square inch, okay, 1 square inch area, you have to count the number of petechiae. So if the petechiae is more than 10, then it is a positive tourniquet test. Okay, I'll tell you once again. So what is tourniquet test? Tourniquet test. So basically, a blood BP cuff is inflated between a systole and diastolic blood pressure. Okay, and then you keep the cuff inflated for around 5 minutes. Okay, then the cuff is deflated and removed. After waiting for 2 minutes, you can see the petechiae happening. Okay, so once the petechiae appears in a small 1 square inch area, you should count the cubital fossa. You have to count the petechiae. If it is 10 or more than 10, then it is a positive tourniquet test. Okay, now tell me, did you all understand this? What is a tourniquet test? Did you all understand? Okay, fine. I'll go further. If you didn't understand, I'll Yeah, okay, thank you. So now now we all came to know what is a febrile phase, right? So next, what happens in this phase? There is fall in the total count. So there is decrease in the total count and the platelet. So sometimes children in the febrile phase itself, they'll recover and go. They might not go to the critical phase. Okay. Next, the fever comes down. So some children, after the fever comes down, they'll enter the critical phase. So in the critical phase, what happens? This is between the 3 to 7 days after from the onset of fever. Okay, so these children might have present with bleed, they might have present with shock, they might present with severe decrease in platelet count, there will be organ dysfunction, there will be liver pathology. Okay, I mean the SGOT SGPT will be raised, there will be what is it, hepatomegaly. So this is how there can be encephalitis. These children can have seizures, or they might go into, or what is it, they might go into an encephalopathy stage. There could be myocarditis. Okay, so this is how a critical phase child presents. So that is why we need to monitor these children very well. So even if a febrile phase, so if a child comes with fever, after 3 4 days, if the fever comes down, we should still tell the parents what are the danger signs and send them, because they can come back with critical phase even after the fever comes down. Okay, so this is critical phase. This develops between 3 to 7 days from the onset of fever. Some children might not enter critical phase at all. Okay, so this is how is a critical phase. So next, go into the recovery phase. So in recovery phase, what happens in after around 24 to 48 hours of critical phase, if the child comes out of that, then it is recovery phase. So the critical phase is generally 24 to 48 hours. Okay, so once the child comes out of it, then it is recovery phase. That is how will you come to know? The activity of the child improves, there is appetite of the child improves, the platelet starts improving. Okay, so this the and even the edema, whatever the edema happened, so in these dengue children, there's a lot of edema. You can see the puffing of eyes, the puffing of the periorbital area. There could be pleural edema. Okay, so all that pleural effusion, sorry. So all that will start coming down. So that will take up to 72 hours. Okay, so this is recovery phase. And in some children in recovery phase, what you can see is there will be rash developing. Okay, so this rash is called as rash or isles of white in sea of red. Isles of white in sea of red. I'll tell you what it is. Have you seen a dengue rash? There is no picture of it right now. I will show maybe in the quiz. So after all the infections are over, I'll be giving a quiz. So that time I'll show you. So isles of white in a sea of red. Sea of red. So what happens is these children will have a completely red skin. Okay, they'll have a red skin. So in between that, they'll have these white spots. Okay, that is why it is called white isles of white in a sea of red. Okay, so that is why it is called like that. Okay, I will show you a picture maybe when we are doing a quiz on this. Okay, and also another very important feature of recovery is pruritus. So they might develop itching. So when a child develops itching, it's very happy. We are very happy that the child is out of dengue. Okay, so that is a very good sign. So developing of a rash, that is isles of white in a sea of red, or development of pruritus, improvement in the appetite, decrease in the edema. These are all the features of recovery phase. Okay, so this you need to know. Now coming to the diagnosis. So now how do we diagnose? So first thing is we have to get a CBC done. So in a CBC, there is increase in the PCV. Okay, then there will be decrease total count, there will be decreased platelet. Okay, so this is how a child with dengue will present in a that picture. Okay, so now in a child who is in shock, there the protein, serum protein, albumin will be decreased. Okay, then if you get a liver function test, the SGOT SGPT will be increased, but SGOT will be sorry, SGPT will be, so once again, sorry, so SGOT and SGPT will be increased, SGOT will be more increased than the SGPT. So this is how you can tell 100% this could be because of dengue. Okay. So next, when you get an X-ray done, there could be pleural effusion can be seen. Okay. Then when you get an ultrasound, so this is a very important in a child with dengue. When you get an ultrasound of the abdomen, what do you see? Do anyone knows? Anyone knows the answer? What do you see in an ultrasound? Ultrasound abdomen of a dengue child. What do you see? Okay, so what do we see? We see the gallbladder is enlarged. Okay, so why do we ask? Okay, the gallbladder is enlarged. Okay, the gallbladder is enlarged and there could be ascites, but main thing why we get ultrasound abdomen is to check the gallbladder. So when the gallbladder is enlarged, okay, again this could be because of dengue. Okay, so these are the things we need to see, and these children will have severe pain in the abdomen, especially in the right hypochondriac region. Okay, so this is how a child with dengue presents. So now coming to the management. Okay, so another diagnosis is the virus isolation, and another is by the IgG, and the NS1 antigen detection. Okay, so this is the antibody, this is the NS1 antigen detection. So this is confirmation for the dengue, confirmatory dengue test. Okay, so now coming to the management. Okay, so now a child with a dengue fever without any warning signs. So now let me tell you what are the warning signs first. So warning signs. So what are the warning signs? So any child who has persistent vomiting. So this you need to know, okay, because this might come as a clinical scenario. That is why this is very important. So they might tell you, so they might tell a clinical scenario with one warning sign. So what the management changes based on the warning sign. I mean, if there is no warning sign, presence of warning sign, or no warning sign. So that's why this is very important. So you need to know all the warning signs because it will help you in a clinical scenario question if any clinical scenario question comes. Okay, so persistent vomiting, severe abdomen pain, any clinical accumulation of fluid. That means what? There could be ascites, there could be puffed, what is it? Edematous face. Then on auscultation, there might be a decreased breath sounds because of pleural effusion. So these are clinical, these are features, this is the findings for clinical accumulation of fluid. Okay, if there is any mucosal bleed. So mucosal bleed is how? Okay, tell me, mucosal bleed. How do you all take by history? Okay, I will finish it off. So mucosal bleed. So if there is any oral bleed in the gums, in the stools, if there is any dark colored stools, okay, if there is any petechiae, so these are all the mucosal bleeds. Okay, in the bleed in the oral cavity. Okay, I've told you know, and even the stools. So always when a child with dengue comes, we have to ask for the color of the stool. Is it any maroonish, blackish, for melena? Yes. So that is why. Okay, mucosal, and if there is any lethargy, okay, lethargy and restlessness. So it could be restlessness or lethargy, both. Okay, next, if there is any enlarged liver of more than 2 centimeters, and then there is increase in PCV. Okay, okay, and there is increase in PCV and concurrent decrease in platelets. So if any of this is there, this is warning signs. You have to hospitalize a child. Okay, so now if the dengue fever without warning signs. God, my class has gone more than 1 hour. My class is supposed to be for 1 hour. Okay, anyway, we'll finish this off fast. Dengue fever without warning sign. Okay, so this here you have to tell the child. You can manage this child at home. Tell the child to have plenty of water, and then daily monitoring of PCV and platelet should be done. So without warning signs. So if there is with warning signs, these children should be admitted in the hospital. Okay, and then the fluid should be given. So um, one second. Okay, so fluid should be given. Okay, so first of all, when the child comes, you have to give us you should always give crystalloids in a child with dengue, so either RL or normal saline. So first you give in a child with warning sign, you give 7 ml per kg of fluids, okay, for 1 hour. And if the PCV is decreasing, you can reduce to 5 ml per kg. Then you can after 2 hours you can reduce to 3 ml per kg. Okay, so this is how it should be maintained. So this is the least what we give in a child with dengue. But now what happens if the PCV is only increasing? So if it is increasing, you have to increase the fluid to 10 ml per kg. Okay, but still the PCV is not improving, then you go for 15 ml per kg. Okay, watch for like 3 hours. Till the PCV is not improving, then you can give colloids, 10 ml per kg. Okay, so this is how you monitor a child. Okay, so if there is no further improvement, so now if it is a severe dengue, so now if there is no if the what is it the child doesn't improve with colloids also, then it is severe dengue, right? So severe dengue. So severe dengue is how? So there is child has respiratory distress because there is excess fluid accumulation. Okay, there could be severe bleeding. There is severe other organ involvement, like the SGOT, SGPT is highly raised. So that time what we should do is, first of all, you have to give a bolus. Now in you have to give a bolus of 10 to 20 ml per kg. Check the blood pressure. If the blood pressure is not recordable, you give a 10 to 20 ml per kg bolus. Then you give 10 ml per kg. So this much is over, 10 ml per kg of colloid. So next what? So next you have to give blood transfusion. Okay, so over here platelets, FFP are not given. You have to do blood transfusion. Okay, in a child with dengue. So if the colloid is also not helping in improving the PCV, you have to go for blood transfusion. Okay, so if there is severe bleeding, if there is severe bleeding and the blood transfusions are also not helping, that time you can go for FFP or and platelet concentrates. Okay, this is only when blood transfusion is not helping to revive the child. Okay, so first of all, we'll just do a fast revision of this. So if the child with warning signs come, you start with 7 ml per kg of crystalloid fluids, either NS or ringer lactate. Watch for 1 hour. If the PCV is improving, if PCV is decreasing, reduce the fluids to 5 ml per kg. After 2 hours, if the PCV is further decreasing, you reduce to 3 ml per kg, and this becomes a maintenance for 24 to 48 hours. Okay, now you are giving 7 ml per kg, but there is no improvement. Then you give 10 ml per kg. Okay, watch for another hour, but there is no improvement. You give for 15 ml per kg of normal saline or ringer lactate. Watch for around 2-3 hours, but there is no improvement. Then go for colloids. Okay, 10 ml per kg. If there is no improvement, then you should go for blood transfusion. Okay, even after blood transfusion, if there is no improvement, then you go for FFP and platelets. That is the last. There is no indication for FFP or platelet otherwise. Okay, so this is how you manage these children. Okay, and if the child is requiring what's it, a lot of fluid, but the child is not in shock, you can even slowly give furosemide, a dose of diuretics. Okay, because there is a lot of fluid accumulation. But if the child, no diuretics, that is furosemide. Okay, so this much is enough for y'all. So this is how you manage a child with dengue. So if you all have any doubts in dengue, no, please ask a question in the comment section. So after you all revise, maybe you all after this you can go back and read about dengue. So if you all have any doubts, please write in the comment section. I'll get back to you all in the next class. Okay. So now coming to the influenza. So influenza is a RNA virus of the Orthomyxoviridae family. Okay. So now in the influenza there are two types. Okay, influenza A and influenza B. Okay, so the influenza A, it is two types, that is based on the surface proteins. One is the hemagglutinin, that is H, and next is the neuraminidase, N. So in the influenza B, it is classified as Yamagata. It is just the name Yamagata and the Victoria. Okay. So how do these infections spread? So these spread because of droplet infections, airborne infections. Okay. Yeah. Yeah. Airborne droplet infections or through contact. So another thing is because of these, what is it? Antigens, there could be antigenic shifts. Okay, antigenic drifts and shifts, they say. You all know about antigenic shifts and drifts, right? Okay, so what happens every time this antigenic drifts and shifts happen, the virus itself is evolved. Okay, so what happens is, so every time this antigenic shift and drift happens, there can be an epidemic happening. So that is why the H1N1 vaccine, the influenza vaccine which is given, that is only what is it, effective for a year. So then you have to repeat again after another year for the next season. So that is why the influenza is the virus, because of the antigenic shift and drifts, it keeps having changes in its configuration, and that is why an epidemic happens. So first epidemic of influenza was in 2009. Okay, so around how much, around 18,000 deaths happened in the world. In India it was 2,000 deaths. Okay, but in India again there was a, so in 2009 it was a pandemic. Okay, in 2015 it became an epidemic in India. Epidemic. Okay, that time again around 2,000 people died. Okay, so that is why now the H1N1 vaccine has come, which is given every year. Okay, fine. So now coming to the clinical features. So clinical features, first of all, there could be minor symptoms like a prodrome phase, minor symptoms. So, but these H1N1 affect the extremes of age. So you should remember this. Yeah, small change and large change in genetic material means, yeah, small, yeah, that is what, change in the genetic material. Correct. Okay. So now, what was I telling? Yeah, so this affects an extreme of age. So the children less than 2 years and elderly. So it can be serious in these age groups. Okay, so how does it present? So first of all, it is minor symptoms. So if the child person is immunocompromised, or if it is a small child less than 2 to 3 years, or an elderly person, or a pregnant woman, so these are an immunocompromised person, so these people are, yeah, so these people are more prone to the complications of the disease. Okay, so especially also people with asthma. So the complications are what? So they can have pneumonia with acute respiratory distress syndrome. Okay, so that is why, so these people might end up being ventilated. So ventilation, in during ventilation, the morbidity and the mortality can increase. Okay, and sometimes they might present with respiratory failure, shock, failure and shock. Okay, so this is how, this is basically what happens is they have minor symptoms. But if you have a certain what is it, immunocompromised state, being an elderly person, or any secondary disorder in you, so these people can go to the complications of H1N1. Okay, so how do you diagnose these children? So diagnosis is by a PCR, antigen detection, and PCR. So PCR is done taking the throat swab or the nasopharyngeal swab. Okay. So treatment is by the M2 inhibitors. So M2 inhibitors are amantadine and rimantadine, and the neuraminidase inhibitor. So neuraminidase inhibitors are oseltamivir and zanamivir. Okay, so but oseltamivir is commonly used. That is because nowadays there is you see that there is resistance to virus resistance to M2 inhibitors, so oseltamivir is used. So viruses which are infections which are resistant to even the oseltamivir, in such conditions we go for zanamivir. Okay, so M2 inhibitors and neuraminidase inhibitors were used, but now the drug of choice, the first line of drug is oseltamivir. Okay, so this is how do you manage a child with the H1N1, that is influenza. And if these children have secondary bacterial infection, you should manage them with appropriate antibiotics. Okay. Oh, this is okay. Yeah, Tamiflu is oseltamivir. You should not tell Tamiflu. You should always tell it as oseltamivir. Always a generic drug should be said. Okay. Now coming to the clinical features of Zika. So Zika virus is a RNA virus from the Flaviviridae family. Okay. So here the vector is Aedes aegypti. Aedes aegypti. So now there are not many cases. I mean, the cases have not been seen in India, Zika virus, but since we have the vector Aedes aegypti, there are chances that this virus might come to India. That is why the concern is on Zika virus. Okay, so yeah, so one is that spread, one is through the Aedes aegypti, the other is there could be vertical spread, that is from the mother to the child. There could be sexual or through blood transfusion. So these are the transmissions of Zika virus. Okay, so there is vertical transmission, then there is sexual, and with blood transfusion. Okay, so how do these children present with? So one is there can be low grade fever, arthralgia, arthralgia, myalgia can be there. There could be rash, conjunctivitis, lymphadenopathy. Okay, they present similar to dengue and chikungunya. Okay, and they can also present with Guillain-Barré syndrome, myelitis, meningoencephalitis. These are the complications of Zika virus. So there are two. This is the two major things. So the one is a Guillain-Barré syndrome. Then other thing is they have teratogenic effects. So teratogenic effects, what happens is if the Zika virus affects you in the first or the second trimester, there could be abortions, there could be intrauterine deaths, there could be stillbirths. After the birth, what complications can happen? There could be microcephaly and ocular abnormalities. So remember, this was the main thing which was said for us in pediatrics, that once the child is born, there could be microcephaly, okay, and ocular abnormalities. Fine. So what is the diagnosis? How do you diagnose? RT-PCR. PCR is done in blood. So this is done in the first 7 days. First 7 days. After 7 days, you do a IgM ELISA. Okay. So this is what is done, and the treatment is, no treatment is still found for this. This is a symptomatic management and no vaccine yet. So they are developing vaccines, but still there is no vaccines available. So the treatment is and vaccines are being developed. This is what. So yeah, so Zika virus is an RNA virus which is from the Flaviviridae family. So how do they present? They present with fever, arthralgia, myalgia, conjunctivitis, rash, and lymphadenopathy, similar to dengue. And the complications are two. You need to remember the complications are: one is neurological syndromes, secondly is the teratogenic effect. So neurological is, they can present as Guillain-Barré syndrome, they can present with myelitis, they can present as meningomyelitis. Teratogenic effect is more we are concerned about, because there are more abortions, there is more stillbirths, there could be microcephaly after birth and ocular abnormalities if the patient is affected between the first and the second trimester. How do you diagnose? You diagnose by RT-PCR in the first 7 days of suspicion of Zika viral infection, and if it is more than 7 days, get an IgM ELISA done. Okay, so Ebola virus is a RNA virus from the Filoviridae family. Okay, so the reservoir of this is a fruit bat. Okay, so incubation, I don't want to Yeah, so basically these present with headache, fever, weakness, nausea, abdominal pain, joint and muscle pain. So the diagnosis in the diagnosis is by leukopenia and thrombocytopenia. So this is not there is nothing much. So remember, fruit bat is the um, reservoir. This is what you need to remember. Otherwise the symptoms are similar. Okay, the diagnosis is there will be leukopenia and thrombocytopenia and IgM, ELISA, PCR, and virus isolation. Okay, and the treatment is symptomatic. Okay, emerging viruses in India. So this you remember. So the Crimean Congo. I'm not going to talk much about all this. Crimean Congo hemorrhagic fever virus. So this is caused by the Crimean Congo hemorrhagic fever virus. This is a RNA virus from the Bunya viridae family. Okay, so this was first reported in India in 2011 in Gujarat. Okay, so this has a presentation like a viral hemorrhagic fever. So you can think of dengue fever when you're thinking of Crimean Congo hemorrhagic fever. Okay, so but in these cases there could be rhabdomyolysis. Rhabdomyolysis. Okay, and the diagnosis is by PCR. Okay, so treatment is supportive, but if you've detected this Crimean Congo hemorrhagic fever early, the treatment you can use ribavirin. Should be used early in the early course of the disease. Okay, ribavirin. Diagnosis is PCR, first seen in India in 2011 in Gujarat. Okay, this is the RNA virus from the Bunyaviridae family. So now coming to hantavirus. Again, hantavirus is a RNA virus from the Bunyaviridae family. Okay, so now, so the hantavirus, no, it can present two ways. One is as a hemorrhagic fever and renal syndrome. Okay, another is hantavirus cardiopulmonary syndrome. Okay, so the hemorrhagic fever and the renal syndrome is seen in the Europe and Asian countries, that is even India, while the cardiopulmonary is seen in the American countries. Okay, so over here the first time it was seen in Tamil Nadu in India, and here you can treat with ribavirin. Treatment is with ribavirin. Okay, sometimes there is co-infections with leptospirosis. Nipah virus is a RNA virus, RNA virus from the Henipavirus family. Henipavirus family. Virus family, that is again from the Paramyxoviridae family. Okay, so this was seen in the West Bengal. This is transmitted to the pigs and humans by the bats. Okay, so mortality is very high, it is up to 70%, and treatment is symptomatic. Then there is Chandipura virus. So Chandipura virus is again a RNA virus. This is from the Rhabdoviridae family. Rhabdoviridae Rhabdoviridae family. Okay, so the here it is because of a sand fly. It is a bite of the sand fly. Bite of a sand fly. Remember, infected sand fly. Okay, so over here again there is a lot of neurological sequelae happening. So just remember this. Chandipur virus, it is a RNA virus which is from the Rhabdoviridae family. It is because of the bite of a infected sandfly, and then there is a high mortality, and then there is neurological sequelae in Chandipura virus. These are the emerging viruses in India. See, all these have been there in India. So the Crimean Congo was in Gujarat. Okay, hantavirus was first in Tamil Nadu. Nipah was first in West Bengal, and Chandipura, I think it's in Chandipura. Okay, So this is another emerging for viral encephalitis, emerging cause for viral encephalitis. Okay, so we have done a 1.5 hour class today. So this is was for today. So I've covered most of it. So I have not done hepatitis, viral hepatitis. That I'll be doing in when I'm discussing GIT. Okay, and then I'm not discussed HIV. So HIV again takes a lot of time. I will do in one of these classes. So today is this much. So tomorrow we'll be discussing about bacterial infections again at 1 p.m. Okay, so all the bacterial infections which common in pediatrics we'll be discussing today. So how was the class? Hopefully you all have understood well. There is a lot, I mean, but if this much is enough. So this much is enough for your NEET PG 2021, for whatever you're preparing for. um, because I have, not knowing all the symptoms won't help you. Okay, so all the viral infections present similarly, but you need to know what is the pathognomic or the characteristic feature of these. Okay, like I've told you these, because when they give you a clinical scenario, that pathognomic feature itself will help you to come to the diagnosis of the disease. Okay, so all the characteristic features and pathognomic features should be known. Okay, as I always tell, yeah, MCQs I will take a class on MCQs once I finish all the infections, because I want you all to be able to answer all the questions that time. Okay, um, yeah, because you see, I'll be doing bacterial infections, rickettsial infections, fungal infections, tuberculosis. There's a lot. So I'll try to put MCQs at the end. But see, today only 1.5 hours it took, because then it will be too tiring for you all to continue the class. So I will do MCQs. Maybe I think it's on Saturday. The MCQ should be on Saturday. I will let you know. I'll tell you tomorrow. I will put the topics what I'm discussing this entire week. Okay. So, and also tomorrow or day after tomorrow, I'll be starting a neonatology class in the subscription in the YouTube channel. Not in the YouTube channel, in the subscription, the Unacademy app. Okay, that's only on neonatology. So there are around 13 classes which I'll be discussing only about neonatology. Okay, so this is for today, and study daily. Studying every day is your end. It is everything. So reading every day helps you a lot, because that laziness won't come in. And another thing is, be away from social media, because that will make you all waste a lot of time. Okay, and if you all have study partners, please discuss topics with them, so that will help you remember better. Okay, so this is for today. All the best. Good luck.